Nursing students and new graduate nurses, get ready to have your socks knocked off, because I am going to teach you today what I know they did not teach you in nursing school about this right here, heparin-induced thrombocytopenia. Find something to write on, pull your chair to the front, lock in, and let us learn. Lord help me, I'm excited already. Okay. Heparin. This is a blood thinner, an anticoagulant to be specific. Any nursing student, seasoned or new grad, who has done any sort of work in the hospital setting, we are very familiar with heparin, okay? Heparin is a medication, like I said, a blood thinner, anticoagulant that can be used for a lot of different reasons. Bottom line is, because it is a blood thinner, it can come with the risk of bleeding. Makes sense, go hand in hand. When you especially are giving patients heparin routinely, whether it's by subcutaneous injection, that's a direct injection that goes into the fatty tissues, usually like the lower part of the abdomen, sometimes it can be like the back of the arm. Nonetheless, whether you are giving your patient heparin that way or if they are getting it through continuous IV infusion, there is one particular test that you have got to be mindful of. And this is not part of any algorithm. I'm not talking about your PTT or your APTT or your PT. No. There is one value that you have got to be mindful of, student nurses, and that is your platelet count. Because if your patient ends up becoming positive, test positive for heparin-induced thrombocytopenia, that actually puts them at an increased risk of clot formation. Let me help you connect the dots. Heparin, again, watch your platelet count. If you have a patient who you are looking at their platelet count by way of the CBC lab test, you're looking at this value every single day. If you see that platelet count dwindle 30 to 50% from baseline, that there should trigger a flag that you need to contact the attending provider and let them know, hey, this patient's been on heparin for X amount of days or X amount of time, and I see that their platelet count has dropped from this to this. Remember, we're looking for anywhere between a 30 and 50% decline, all right? Once that decline is observed and communicated over to the attending provider is going to put in an order for what is called a HIT panel, heparin-induced thrombocytopenia panel. The purpose of that panel is to look for a particular antibody. It's the HIT antibody, all right? Now, if this patient's HIT antibody test turns up to be positive, this patient is going to need a secondary blood thinner. So it dawned on me when I was a floor nurse myself, because I could not make sense of it back then. I get it now, but back then, I said, well, if this patient is on a blood thinner, right, and their platelet count, which is a marker of how well they are going to clot, if that platelet count continues to decline, wouldn't it be advisable to stop any blood thinners to lessen the likelihood or lessen the risk of them bleeding any further? To me, that was the logic. And on the surface, that is very logical. But here's the kicker. And this is what they don't teach you in nursing school. If your patient tests HIT positive, what happens? That antibody, that HIT antibody, metabolically speaking, will then talk to the platelets, and it'll talk to the monocytes. These are a portion of the white blood cells. It'll activate, actually. It'll activate those platelets, and it'll activate the monocytes, and that triggers the immune response. When the immune response is triggered, the inflammatory response is triggered also. When that happens, that actually sends the body into what is called a procoagulant state, which means they are actually at increased risk of blood clot formation, despite the fact that they have a lower than normal platelet count or a declining platelet count. It's like a switching, what do you call it? Bait and switch. When I tell you that blew my mind, the very first time that I learned about that, I said, so you can have somebody on a blood thinner, like a good, potent, strong blood thinner, heparin, and then because of the body's own chemical makeup, metabolic makeup, their body is so resistant to heparin that it does like a whoop-de-doo reversal, like a reverse in Uno, gotcha, and actually sends the patient into a pro-coagulant state. Blew my mind, absolutely blew my mind. This is why when patients hit positive, why the heparin is stopped, and you still need to employ a blood thinner to minimize the risk of brand new blood clot formation or worsening of the blood clots that already exist, for which the heparin was being used for in the very beginning. This is why patients are switched over to, more likely than not, a brand new IV medication called argatroban. Mind blown. Let that absorb. Review this material again if you need to, a couple of times. Of course, I always advocate that you do your own research as well. Let me know your thoughts. If this information has piqued your interest, like I know it has piqued mine, and you want to learn about more, baby, stay in the classroom. Very easy to get in. Just hit your plus button up there, follow along. I will teach you about all the things that they don't teach you about in nursing school, but things that you need to know when you are becoming an actively practicing nurse. That's going to conclude it for today's class. Y'all are dismissed.